To Sabine.
Thank you very much. Thank you for this kind introduction. So should I start?
Go for it.
Should I start?
Yes, you can start.
Okay, fine. So just a moment, please. Okay. All right. So thank you very much for this kind introduction and good morning, everyone. I hope you can hear me well. I would request you to please put your mics on mute so you can hear me better. Is that okay? Hello?
Yes, doctor.
Yeah, please can you put the mics for the audience on mute? Thank you. Can you hear me now?
Yes, doctor. Much better.
Okay, fine, perfect. So good morning, everyone, and thank you very much for joining the session today, and thank you for your kind introduction as well. So today I'm going to talk about rheumatological diseases in pregnancy, and it's the topic is really very important because we see more and more of these women coming to our clinics nowadays, and it becomes even more important because of the newer medicines that these women are using and they've been prescribed, and the dilemma whether to continue them in pregnancy or whether to change them and how to deal with the situation. So it's really a vast topic and it's very hard to cover it in this short time, but I have tried to divide my talk into three major groups. So I will introduce you to some of the common diseases that we see in the clinic. Then we will talk about the medications, specifically the biologics that are newer to most of us, the effects of these conditions on pregnancy and the effect of pregnancy on these conditions. So the term rheumatological diseases or connective tissue disorders or autoimmune conditions, they are all interchangeable terms with a little bit of differences among them. The most important thing to remember is that most of these diseases are commonly found in females. So they have a higher incidence in female, and majority of these conditions present during the reproductive years of women. As you can see, that I have listed some of the conditions for you. Systemic lupus erythematosus is probably the most common one that we see in our practice, followed by rheumatoid arthritis, and then some other conditions like Sjögren in association with rheumatoid and sometimes really alone, scleroderma, some mixed connective tissue disorders, and some of the vasculitis. So as I have just said that all these diseases or most of these diseases are more common in females. So you can see the female to male ratio, let's say for systemic lupus erythematosus is about, it can be as high as 15:1. And mainly these diseases, they present during the reproductive years of the woman. So it's a likely chance that we will see them when they are pregnant. And sometimes even the first diagnosis is made during the pregnancy. When we talk about connective tissue disorders, the first thing that comes to mind are the various type of antibodies. And I think possibly most of you are aware and more familiar with the commonest antibody that we look for is the anti-nuclear antibody. So anti-nuclear antibody is the first antibody that we look for or we test for. And as you can see that it is present in most of the conditions that we come across with. So it is found in SLE as well as rheumatoid, mixed connective tissue disease, although the percentage is variable. The three other antibodies that I would like to highlight over here in respect of pregnancy are the double-stranded DNA antibody. So double-stranded DNA antibody is highly specific for SLE. Anti-double-stranded DNA is used, first of all, to ascertain the disease activity. Then it can also be used to diagnose the flare, which can happen during the pregnancy. The other two antibodies are anti-Rho and anti-La antibody. And I would emphasize on the importance of these antibodies because of their association with congenital lupus. So we will talk about these in the later slides, that how congenital lupus presents and what is the importance of these two antibodies. So the basic problem that we come across with in the clinics is about when these women are coming to us, they are on different kind of medication. Many years ago, these women used to be treated only with analgesics, NSAIDs, steroids, and some of the older disease-modifying drugs like hydroxychloroquine, methotrexate, etc. But as medicine has progressed, we are seeing more and more of new medications like TNF inhibitors, larger biologic molecules. So there are many new drugs which we are not familiar with, and we find it as a challenging situation. I have tried to simplify these medications in the form of this table. So let's start with a simple one. So let's start with the simple analgesics like paracetamol, NSAIDs, and steroids. So all of these three medicines are safe to be used during pregnancy. There are a lot of questions about use of NSAIDs during pregnancy. They are not teratogenic. They can be used in pregnancy in the first and the second trimester. However, there is an increased risk of oligohydramnios when it is used beyond 20 weeks. So if you can avoid it, it's good. If it is unavoidable, a small dose over a period of small time can be given to relieve the symptoms. Another problem with NSAIDs is the risk of premature closure of ductus. So ideally, these medications should be discontinued by about 30 to 34 weeks of gestation so that this complication can be avoided. For the steroids, you are well aware about steroids. All the steroids are safe to be used during pregnancy. Betamethasone and dexamethasone cross the placenta. However, prednisolone does not cross the placenta. So if your patient is on prednisolone for her disease and you need steroids for lung maturity, she still needs to be given beta or dexamethasone. This is the most common question which is asked. So, use of steroids in pregnancy increases the risk of gestational diabetes, it increases the risk of infection, and it also increases the risk of preterm rupture of membranes. So ideally, that these steroids have to be used in the smallest possible dose, which is required to relieve the symptoms. Another important aspect is the stress steroids. So if your patient has been on, let's say, prednisolone over 5 milligram over a period of at least 3 weeks, then she will require stress steroids during labor and delivery. Sorry. The other medications are like the disease-modifying drugs that have been used for a very long time, like hydroxychloroquine, azathioprine, sulfasalazine, and colchicine. All of these drugs are also safe to be used in pregnancy. In fact, azathioprine can be started in pregnancy as a steroid-sparing agent. And sulfasalazine, if your patient is on sulfasalazine, you can continue throughout the pregnancy and breastfeeding. However, she needs to be started on extra dose of folic acid because sulfasalazine affects the folate metabolism. Hydroxychloroquine is perhaps the most famous drug used in most of the autoimmune condition. It is absolutely safe to be used in pregnancy and breastfeeding. There had been some questions about the ocular involvement of the neonate when the woman has been on hydroxychloroquine. However, there is a lot of data which suggests that there is no untoward effect or no side effect on eyes or the vision or the ocular involvement of the babies whose mothers have been on hydroxychloroquine. Hydroxychloroquine does cross the placenta. However, the congenital abnormalities rate is not higher than the general population. Why hydroxychloroquine is so important? Because it is one of the only drug which has found to reduce the risk of congenital heart block if the mother is anti-Ro or anti-La antibody positive. So there is a lot of data which is suggestive that use of hydroxychloroquine not only prevents the congenital heart block, however, it also prevents the relapse and the flare in pregnancy. There are certain group of drugs which are used otherwise, but they are not safe to be given in pregnancy, like mycophenolate, methotrexate, leflunomide, cyclophosphamide, for example. These drugs have been found to be teratogenic in animal models, and they are contraindicated to be used in pregnancy and breastfeeding. Leflunomide has a very long half-life. So if a woman is on leflunomide for her, let's say, rheumatoid arthritis, she has to stop the drugs at least 2 years before she tries to conceive. Cyclophosphamide is also contraindicated in pregnancy, but there are certain indications for which it still can be given in the second and third trimester. Like, for example, if someone has a severe interstitial lung disease secondary to a systemic lupus erythematosus, secondary to systemic sclerosis. Now, the newer drugs. So there are two types of newer drugs. TNF inhibitors. The TNF inhibitors have been in the market for several years now. I would say people have a lot of experience with these medications now, and we have seen many patients on these medications. The commonest one that we see is infliximab, etanercept, adalimumab, certolizumab, etc. All of these tumor necrosis inhibitor are actually the antibodies. They are monoclonal antibodies. Certolizumab is a little bit different from them because it lacks an Fc fragment. These drugs are absolutely safe to be used in pregnancy. They have no teratogenicity, embryotoxicity, or pregnancy losses associated with their use. However, all of them, they cross the placenta except for certolizumab. It does cross the placenta, but in very minimal or negligible amounts. So if you do the cord levels of these drugs, the cord levels can sometimes be several times higher than the maternal levels. That's why, and because, you know, they are all immunosuppressants. So if your patient is on one of these medications and she has to continue it throughout the pregnancy because of her poor disease or her disease which is not in remission, then you have to inform the neonatologist. You have to discuss with them, because the vaccination with the live vaccines for these babies, like for example BCG, has to be delayed until at least 6 months. So if possible, if the woman is in remission, she's symptom free, she's otherwise okay, and her rheumatologist or her physician agrees, then these drugs possibly can be discontinued by 28 weeks, 30 weeks or so that the drug level in the infant can be washed out and the baby can be vaccinated. All of these drugs are absolutely safe to be used during the lactation as well. Then there are other biologics. So many of these drugs are coming every day, every other month we see that a new drug is launched in the market. So like ustekinumab, tocilizumab. Tocilizumab, maybe some of you are already familiar with the name because of its use during COVID pandemic, and we used it in pregnancy as well. And there has not been any untoward effect on the baby that is seen, that was found in women who are exposed to tocilizumab during pregnancy, even in the last trimester. So these biologics, some of them are larger molecule, most of them, some are smaller molecules. They do not cross the placenta until at least 12 weeks of gestation. And because they are new, so there is no clear recommendation about their use and at what stage of pregnancy they should be stopped. If the disease is not in remission, then the general consideration is that they could be continued throughout the pregnancy. And again, the baby should not be given the live vaccination. And of course, all of them are safe to be used during breastfeeding. Now, because the topic of rheumatological diseases is so vast, I have chosen two diseases as a general discussion, like systemic lupus erythematosus and rheumatoid arthritis. So first, I will talk about SLE. SLE is diagnosed on a basis of a combination of clinical symptoms and clinical signs, as well as some of the lab parameters. What's important for us in context of pregnancy is the presence of certain antibodies, like, for example, double-stranded DNA, which is used in pregnancy to monitor the disease activity. It is used in preconception period to find out if the woman is already in remission. And it is also used to differentiate between a flare of SLE or, like, let's say, preeclampsia. Sometimes a flare of lupus nephritis mimics preeclampsia. At this stage, dsDNA really is helpful to differentiate between the two. The other antibodies are which are important are anti-Rho and anti-LAR antibodies. They are seen in up to 30% of cases with SLE, and they are associated with congenital heart block. The risk of congenital heart block is about 2%. Another aspect is antiphospholipid antibodies. So 40% women who have SLE are found to have APS, which is secondary APS. And why is it important? We will see in the subsequent slides. There is a study which I would like to highlight over here, although it's quite old, it's from 2008, but still very relevant today because of the number of the size of the women, or the volume of the women that they used in this study. Is about more than 13,000 women. So it's a national study for the complications of lupus in pregnancy. And in this study, which was carried over a period of 4 years, they found increased risk of thrombosis, infection, thrombocytopenia, high risk of cesarean section, preterm labor, and preeclampsia. The mortality in this study, maternal mortality, was 20-fold higher than the general obstetric population. Fortunately, this number has come down in recent years because of the advances in medical management of these conditions. Now, how pregnancy is affected by SLE, I have highlighted the important things in green. So it increases the risk of women of having preeclampsia up to 30%, especially if there is proteinuria from before, if the woman is hypertensive, or she has lupus nephritis. The percentage of preterm birth is up to 50%. Preterm births are more common in women who have lupus nephritis. There is a variable risk of fetal loss, especially the fetal loss is more common when there is secondary APS. The fetal growth restriction can be seen in up to 30% of these women, and more common again in women who have lupus nephritis. Neonatal lupus, so the risk of congenital heart block is about 2%, and it is more often in women who have anti-Rho or anti-LAR antibodies present. So how and pregnancy affects SLE. Pregnancy increases the risk of flare. About 40 to 60% women have a flare of SLE during pregnancy and puerperium. And this risk is even higher if the woman is primigravida into her first pregnancy. She has history of lupus nephritis. Her disease is not well controlled before conception, or she discontinues hydroxychloroquine. There has been a lot of studies about use of hydroxychloroquine during SLE when the woman is pregnant, because it does reduce the risk of flare in these patients. So how do we manage them? So please bring these women to preconception clinic if they are not pregnant and they're planning to get pregnant. So when we see these women in the preconception clinic, we try to do the risk assessment on an individual basis. We anticipate what kind of complications they can have during pregnancy, and we counsel them accordingly. There are laboratory investigations that can be carried out to see the disease activity, as well as to anticipate the complication and the other risk, like let's say the dsDNA level, complement level, looking for anti-Rho, anti-LAR antibody, finding out the baseline renal functions, etc. So ideally, a woman should be at least for 6 months in complete remission before she plans pregnancy. And that's the purpose of the preconception clinic. Now, another issue with these women is the medication management. So as you saw earlier, that some of these medications are not compatible with pregnancy. So it is better to change the medications from before she gets pregnant, so that she passes that period smoothly, her disease remains in remission when she enters pregnancy. So we have to actually weigh the risk and the benefits of keeping the medication, and we try to use the medications which have better safety data during pregnancy. When these women are pregnant, I will emphasize on the use of MDT care. So please involve and the physicians, involve the rheumatologists, the fetal medicine people, neonatologists, nursing, and of course obstetrician. They are the most important people because the woman is coming to them pregnant. So please involve all of the team to give the best possible care to these women. Because as a physician, we would monitor their disease activity. Fetal medicine people will monitor their fetal growth parameters. And of course, this woman needs a MDT care to have a safe pregnancy journey as well as a successful outcome. For women with SLE, start them on aspirin from 12 to 16 weeks of gestation because it is known fact that aspirin reduces the risk of preeclampsia. There are a lot of questions about how much aspirin to be used. So 75 to 150 is fine. There are certain studies which advocate the use of 150 milligram because it is found to be superior than 75 milligram. But even 75 milligram is found to be better than no aspirin. There is sometimes confusion about an 81 milligram dose. The 81 mg dose is available in the US. So like we use 75 over here, they use 81 over there. Then you have to consider low molecular weight heparin. So if your woman has got, let's say, secondary lupus, or she has history of thrombosis, so we have to consider the use of low molecular weight heparin in these women. You have to continue hydroxychloroquine. If your patient is not on hydroxychloroquine, you can start it during pregnancy, and you have to manage the other medications that she's already using. And one more important thing is that there is a risk of flare during pregnancy. So you have to know and be familiar with the symptoms of flare, how to identify it, and how to treat the flare. So as I discussed earlier, that the rising titer of dsDNA, presence of RBC cast, fall in the complement level, these are all lab investigations which help us to especially identify or differentiate between preeclampsia and the lupus flare. The treatment for lupus flare is corticosteroids. Now I will talk a little bit about neonatal lupus syndrome. So the neonatal lupus is more commonly seen in women who have anti-Ro antibodies and women with anti-La antibodies. The risk of cutaneous lupus is about 5%, and the risk of congenital heart block is about 2%. This risk increases to 50% if the woman already has 2 children affected with this condition. Use of hydroxychloroquine, like I discussed earlier, has been shown to reduce the risk of neonatal lupus or congenital heart block in these women. This is a picture showing cutaneous lupus syndrome. So the cutaneous neonatal lupus actually presents with erythematous skin lesions. They disappear spontaneously. However, there can be some residual hypopigmentation that can persist for up to 2 years. In contrast to cutaneous lupus, which goes away maximum by the period of 2 years, congenital heart block is permanent and it is fatal. The mortality is up to 20%. Congenital heart block is detected by about 18 to 28 weeks of gestation on fetal echo. There is no treatment to reverse this heart block. 20% of the children who, as I said, 20% of the children who are affected with this condition actually die in early neonatal period. Up to 60% of the children require pacemakers. So important to remember in SLE is an MDT care. So we can monitor the disease activity, monitor the pregnancy pathways, look for anti-Ro and anti-La antibody when these women come to your clinic, continue them on their hydroxychloroquine, adjust the dose, 400 milligrams per day is the usually recommended dose. Do a fetal scan or echo to look for congenital heart block, start them on aspirin so that you can prevent preeclampsia, and low molecular weight heparin if she has APS or what according to the risk profile. Most of the women with SLE, we recommend to give them at least 6 weeks postnatal thromboprophylaxis. The other topic is antiphospholipid syndrome. Antiphospholipid syndrome, although it is not directly a rheumatological condition, however, since it's very commonly seen in association with SLE, that's why it's important to discuss it over here. So antiphospholipid syndrome or APS is a combination of venous or arterial thrombosis with or without pregnancy loss and in the presence of antiphospholipid antibodies. So there are two types of APS. One is the obstetric variety and the other is the non-obstetric variety. The non-obstetric variety is the presentation is with venous and arterial thrombosis. However, the pregnancy variety or the obstetric variety is defined by a criteria which is called Sydney criteria. So by definition, if there are 3 or more consecutive miscarriages before 10 weeks of gestation, if there is more than 1 or more fetal death after 10 weeks of gestation in a fetus of normal morphology, if there is 1 or more premature birth less than 34 weeks of gestation due to preeclampsia or severe placental insufficiency. Why is it important? Because 30 to 40% of women with SLE have APS. Around 30% of those with APS have a risk of thrombosis. About 30% of women have severe early onset preeclampsia. However, antiphospholipid antibodies are also found in 5% of general obstetric population without presentation of any clinical symptoms or clinical history. So if a woman is pregnant with APS, there is increased risk of thrombotic events, venous thrombosis like DVT or arterial thrombosis like stroke or myocardial infarction. There is a risk of worsening of her if there is pre-existing thrombocytopenia. Pregnancy is affected by risk of miscarriages, 2nd and 3rd trimester fetal death, fetal growth restriction, abruption, and preeclampsia. Abruption is not an APS defining complication. However, it is secondary to the placental insufficiency. So a previous obstetric history is the best predictor of pregnancy outcomes. So if a woman is coming to you with one of these conditions, please you investigate her for the presence of APS as well. I would like to highlight 2 more points in APS over here. One is the presence of lupus anticoagulant. So as you know that there are several antiphospholipid antibodies that we look for, like beta-2 glycoprotein, lupus anticoagulant, cardiolipin antibody. Out of all these antibodies, lupus anticoagulant is the one which is predictive of poor pregnancy outcome after 12 weeks of gestation. That's the most common one. Another thing that I would like to focus over here is the presence of triple positive antibodies. So if a woman has got all 3 antibodies positive, like lupus anticoagulant, anticardiolipin, and beta-2 glycoprotein, she has a chance of having a live newborn is only 30%. So they have a really bad obstetric outcomes when they are triple positive. So what should we do? Again, we have to have a multidisciplinary care. A physician should be able to take a detailed history about the thrombotic events that she had, about the previous pregnancies, what was the obstetric outcome, and of course, close fetal monitoring. All these women have to be started on aspirin and low molecular weight heparin, and you will see in the next slide that sometimes how it is decided how much low molecular weight heparin has to be given. And other options. So some of these women who have APS have been on aspirin and low molecular weight heparin, but still they have poor obstetric outcomes. So there have been trials about using hydroxychloroquine, about using prednisolone, and although there is no substantial data about them, but there are individual case reports and some small studies which show effectiveness of hydroxychloroquine and prednisolone in this population. About the use of aspirin and low molecular weight heparin, this is a table which I have used from Professor Catherine Nelson Piercy's book of obstetric medicine. So if your woman has APS, but no thrombosis, no miscarriage, no adverse pregnancy outcome, she can be started from aspirin from preconception. If a woman has a history of previous thrombosis and she is on an oral anticoagulant, then you have to start her on aspirin and you have to start her on full dose of low molecular weight heparin as soon as the pregnancy is confirmed. If the woman does not have any previous thrombosis and if the woman has previous thrombosis, but she is not on an oral anticoagulant, then you can start her with aspirin along with low molecular weight heparin initially in a prophylactic dose, but once the pregnancy advances to 16 to 20 weeks, you can increase it to the full therapeutic dose or a high prophylactic dose. If a woman has a history of recurrent miscarriages before 10 weeks and she is not on any oral anticoagulant, you start her from aspirin. If the woman has history of miscarriage on aspirin, then you add aspirin along with low molecular weight heparin. All the other indications like late fetal losses, neonatal death, adverse outcomes to preeclampsia, fetal growth restriction, or abruption, you start these women with aspirin along with low molecular weight heparin in a prophylactic dose. This is the repetition of the almost the same. Now, the other condition is rheumatoid arthritis. Rheumatoid arthritis is also commonly seen in our practice in obstetric medicine clinics. So it is classified by the American College of Rheumatology, and the new classification came in 2020. It's a combination of symptoms plus serology. I would not go in details about these here. So what we are interested in? We are interested in the presence of the antibodies again. So we are interested in the presence of anti-Rho and anti-La antibodies or secondary Sjogren. So there is no clear data about what is the percentage of secondary Sjogren in rheumatoid arthritis, but one of the registries from US, it actually showed that about 10.3% women who have rheumatoid arthritis have secondary Sjogren. Another antibody that we look for is the anti-CCP, which is citrullinated cyclic polypeptide. This is important for the disease activity. So once the woman comes to your clinic, you have to check the level of anti-CCP to make sure that the disease is in remission, or if the disease is active, then you can have the levels to check for the disease activity during the course of pregnancy. Another important thing to remember over here is again the presence of secondary lupus or APS, which is seen in about 5 to 10% of these women. So the good news about rheumatoid arthritis is that in contrast to SLE, rheumatoid arthritis, 50% women actually have improvement during pregnancy, 20% of them enter complete remission. However, there is a risk of postpartum exacerbation, which is highest in the first 4 months after delivery, and about 90% women actually have a postpartum exacerbation. Again, just like any other autoimmune disease, if the disease is active during conception, when the woman conceives, there is a high risk of miscarriage, preterm delivery, small for gestational age babies. If there is presence of anti-Rho, anti-La antibodies, there is a risk of neonatal lupus, and there are other complications, like, for example, involvement of cervical spine makes the woman at risk of atlantoaxial subluxation during general anesthesia for medical purposes. So what should we do? Like I said, we should screen these women for secondary Sjogrens and the anti-Rho, anti-La antibodies. If they are positive, start on hydroxychloroquine. Do the pain management. So don't let your patients suffer with pain. You can start analgesics. Corticosteroids by far are the best medication to deal with the active disease. Try to start in a good dose, then taper it down gradually to the minimum dose where the woman feels symptomatic improvement. The disease-modifying drugs, whatever she's on, can be continued in consultation with the physician. For the obstetric pathway, of course, the fetal monitoring and the anesthesia referral if you know that the patient has already neck involvement. So these were the two major conditions. There are several other conditions that we see rarely. So out of these, more interest is the scleroderma. So I have seen a couple of patients of scleroderma in pregnancy in last many years. So just maybe 2 or 3 patients actually. So scleroderma, if there is cutaneous scleroderma with localized involvement only, the prognosis is really good. But if the woman has a systemic sclerosis with renal involvement, with involvement of the lungs, secondary pulmonary hypertension, then the risk of pregnancy loss is really high. And also the risk of exacerbation of her disease is very high. So the success rate for a cutaneous limited scleroderma is about 70 to 80%. There's increase of preterm delivery 25%. And as I said, if the disease is severe or systemic, then there is risk of preeclampsia, fetal growth restriction, perinatal mortality. There are some practical problems that we face even with cutaneous scleroderma, like, for example, access of venous access to take the blood samples, monitoring of blood pressure, monitoring of peripheral oxygen saturation because of the involvement of the skin and the blood vessels. Now, women who have Raynaud's, they actually feel better when they get pregnant because of the vasodilatation. Women who have more involvement of esophagus have a more severe reflux during pregnancy because of the decrease in the esophageal tone. There can be another challenge when these women have to have general anesthesia, let's say for a cesarean section, because there might be difficult endotracheal intubation because of the small opening of the mouth. Unfortunately, there has not been any specific treatment that has shown improvement for systemic sclerosis. There are some new treatment like the same biologic molecules, but there is no safety data about them in pregnancy. So we have to bring these women again to preconception clinic. Please bring them, all women with connective tissue disorders, to preconception clinic so that we can assess about their disease activity before they start the pregnancy. So for systemic sclerosis or scleroderma, we do the lung function test to look for interstitial lung disease and lung capacities. We do echocardiography. We look for especially for secondary pulmonary hypertension. We do the renal panel test to look for the involvement of the kidney. And I would advocate an early assessment by an anesthetist as well. Systemic sclerosis is one of the condition in which the flare of the renal condition or a renal crisis can happen with the treatment of steroids. So the use of steroids in systemic sclerosis is really tricky. So if you need to really give steroids for the fetal lung maturity, please discuss it with patient's primary physician or the rheumatologist about the use of steroids. This is just to let you know about some medications that can be used in systemic sclerosis, like for example, interstitial lung disease. If it is not responding to other treatment, and she is responding only to cyclophosphamide, so even cyclophosphamide can be started after the first trimester for her. If the woman is on ACE inhibitors, so you have to see the risk and the benefit ratio of how bad is her kidney disease, so you can continue ACE inhibitors throughout the pregnancy. It is perhaps one of the fewer indication of continuing ACE inhibitors throughout the pregnancy. Now, for Raynaud's, many women feel improvement with nifedipine, which is practically safe in pregnancy, and same is true for the proton pump inhibitors and prokinetics, which are safe medications in pregnancy, and they can be used to reduce the reflux symptoms in these women. One more condition before I end my presentation is Behçet syndrome. We recently had a patient with Behçet with Dr. Sara, and she was admitted for unrelated condition, unrelated problem to her Behçet, but she had Behçet syndrome. So up to 70%, 50 to 70% women actually improve in pregnancy who have Behçet syndrome. Some women have an exaggerated reaction at the site of episiotomy or cesarean section, and this phenomena is called pathergy, and that's why it's important to know about that the woman has Behçet. And the treatment that is used for the management of Behçet is the same, like corticosteroids, azathioprine, calcineurin inhibitors, all are fine to be used in pregnancy. All biologics are fine to be used in pregnancy with the consultation with the physician. Before I end my presentation, I would like to emphasize on some points. So autoimmune or connective tissue diseases or rheumatological diseases, we see them a lot in our clinical practice nowadays because more and more of these women are becoming pregnant. And with the advancement in medical management, they are having successful pregnancy outcomes. So these women have to be monitored in the preconception clinic. Please bring them to the preconception clinic before they decide to get pregnant. The risk of the preeclampsia, IUGR, prematurity is really high in these women. The risk of flare is very high in these women. So they have to be taken care of in MDT clinic setups. We have to have the knowledge about the use of medications, especially the newer ones, and how important it is to continue these medications to have a safe pregnancy without complications and also a positive outcome. So I would emphasize again on the teamwork between obstetrician, collaboration between obstetrician, physician, people from fetal medicine, and of course our nursing. With this, I thank you all and really thank you very much. And if there are any questions, I'm really happy to answer. Thank you.
Thank you, Dr. Sabine. That was very interesting. If there's any questions from anybody, you can unmute yourself. or you can type them in the chat box and Dr. Sabine can address them.
Good morning, Dr. Sabine.
Good morning.
This is Dr. Muhaymin from Danat al-Emirat. Thank you so much for this very informative presentation. I was just wondering if you can share it with the audience or any way to share it with them.
Yes, absolutely. Thank you for joining, Dr. Muhaymin. And yes, I will share it with the audience. No problem.
Thank you.
Thank you.
Dr. Sabine, I think there was a question early on. Somebody's asking what the role of biological agents in the treatment of rheumatoid diseases in pregnancy.
Yeah, I think we talked about it. The biological agents are of two types. So commonly the newer ones are the older ones are the TNF inhibitors, and the newer ones are the larger molecules. All of these they work as immunosuppressants. So the immunosuppressants would reduce the antibody formation in the body. And this is how most of the biologics actually work. They work at different levels. All of them, all these biologics, it's really hard to cover how the biologics work in this talk, but they are immunosuppressants generally. They work at different levels to reduce the antibody formation in the body. And they are being increasingly used nowadays for the treatment of rheumatological diseases. In fact, the whole outcome of rheumatological diseases has been changed since the introduction of these medications. Any other question?
Thank you, Dr. Sabine, for this very informative presentation. Really, like we gain a lot from it. So I would like to ask about patient with psoriatic arthritis.
Mm-hmm.
Any change from what you have been mentioned about in rheumatoid arthritis regarding their care during pregnancy?
No change. Psoriatic arthritis, nowadays, a lot of biologic, especially ustekinumab and certolizumab has been used for it. And like I said earlier, that if the woman is on one of these medications, you can continue them. If the woman is in remission, then you can discuss with the doctor and you can stop it by 28 weeks or 30 weeks maximum. But if she's not in remission, then you can continue it. There is no other extra information or a change from the previous. I hope that answers.
Yes, thank you very much.
Are there any other questions from anybody else? Just before you leave, just make sure you complete the post-test survey and the evaluation form, which is also on the chat box now. But feel free to unmute if you have any further questions for Dr. Sabine.
Can I ask another question?
Of course,
yes.
Go ahead.
Yeah, I am Dr. Ibtihaj from Health Plus. So any role regarding use of hydroxychloroquine for patient with autoimmune thyroiditis?
Yes. So autoimmune thyroiditis, there is no role actually of use of hydroxychloroquine in use of autoimmune thyroiditis. It's a different mechanism, because in autoimmune thyroiditis, although you have to look for other autoimmune conditions in that woman, because the use of hydroxychloroquine is basically, when it was first established, was in SLE. And then it was in context of pregnancy in women who have anti-Ro and anti-La antibodies. So if a woman is coming to you with autoimmune thyroiditis, you have to look for other autoimmune conditions that might be present. And if not, then as such for autoimmune thyroiditis, there is no role of hydroxychloroquine as per my knowledge. Alone for autoimmune thyroiditis, I'm not aware if there's any role of hydroxychloroquine.
Okay, thank you. Thank you.
Welcome. But yes, I want to emphasize over here, because sometimes I have patients who were on hydroxychloroquine, and when they get pregnant, they stop it. So if a patient like this come to the clinic, so please reassure her and provide her the information that she requires about the safety, and reassure her, and please convince her to start the treatment again.
Other questions, I guess we can come to an end.
Yes.
I just want to remind everybody about the certificates. If you are a DOH licensed professional, please ensure to apply on time, and we will get back to you in terms of an approval for your certificates, which you'll get notified for. If you are a non-DOH licensed professional, please send an email to academicaffairs@healthplus.ae and just mention your name and which CME session that you need a certificate for, and we will process this for you. Sorry, Dr. Sabine, there's one more question.
Yeah.
How often biological agents can be given during pregnancy?
So I really don't understand the question. How often mean it means that how often means what is the dosing? So the dosing for different biological agents is different. Some of them are given every 4 weeks. Some of them are given every 8 weeks. Some of them are given every 2 weeks. It all depends on the type of the biologic that the woman is on and the state of her disease. So if let's say ustekinumab, this is given 8 weekly usually. And some of the drugs are given monthly, some are given 2 weekly. So it depends on the different biologics, what's the dosing for them. So if a dose is given like, let's say 8 weekly, so it means it's a very long acting drug. And we have to keep these things in the mind, when to stop it. So it depends on individual biologics. There is no fixed rule that which drug would be given. I hope it answers the question.
So I just want to thank you for taking your time out to do this presentation for everybody as well.
My pleasure. Thank you. Okay, thank you then.
Everybody.
Thank you.